Good afternoon. Thanks for the invite. So I'll be talking on the effect of post-op RT on 3A to N2 NSCLC after the complete resection and adjuvant chemo. This is a randomized port C clinical trial data. So just to give a bit background information, the port meta-analysis first published long back in 1998. We had some survival benefit in the completely resected group, especially the N2 disease, but the RT techniques were quite premature at that time. There were improvement in techniques, and between mid 2000 to the mid 2014-15, few of the articles have highlighted mostly a single center retrospective or small sample size about selected N2 where there is a survival benefit. But the doubt and the queries always remained, primarily due to the toxicities and the adverse events. So there are three randomized control trials investigating adjuvant RT. One is a CalGB 9734, the lung ARC trial, and this port C. Now CalGB 9734 has given 50 gray of port with no difference in DFS and OS. The lung ART, which is published, the prelim result has a statistically non-significant disease-free survival benefit with port. It has not reached statistical significance with about 500 patients. And they have also attributed reduced overall survival, but that might have been due to more of grade 3 to 5 cardiopulmonary serious adverse events. Now this design of the study, which is conducted in National Cancer Center Beijing, has taken histologically confirmed 3A N2 NSCLC, a long time interval between Jan 2009 to December 2017. Patients undergo an adequate surgery first with nodal dissection, followed by platinum doublet 4 cycles adjuvant chemo, and then they are randomized. The radiation dose in post-op adjuvant RT is 50 gray in 25 fractions. Either 3D CRT or IMRT techniques were used, and the target volumes included the ipsilateral hilum, mediastinum, also the subcarinal regions. Radiation should start within 6 weeks from the last chemo, and no interruptions beyond 10 days were allowed. And on the right, these are the dosimetric parameters, as we call it, for the lung and other organs. Now, pre-enrollment, all patients should undergo the routine blood test, a CT thorax with bone scan if PET is not available, also an MR brain, and the standard follow frequencies were followed. The primary endpoint when disease-free survival, which is like date of randomization to disease recurrence or death, whichever is earlier, and these are the secondary endpoints, and the adverse events were recorded as for CTC version 3. So this is the randomization schema, which is more or less well balanced between either of the arms. So this same group from Beijing has actually published their retrospective series about 220 odd patients, and they have shown an improvement in DFS and OS with the port. And mind it, they have used 2D RT also at that time. Not all were, there were no IMRT for that matter. And they've given a sort of a stratification between the groups done surgery, then chemo and radiation. If you look at the median survival time, the 1, 3 and 5 year OS, they were all favoring the addition of port. And that's the primary reason where they have projected this randomized data. So I've done something called modified intention to treat analysis. They were well balanced between the port and the observation group about the numbers. The median DFS was 48 months, and they put a pre-trial set of 230 DFS events to occur at the time of analysis. The median disease-free survival was 22.1 months in port arm with 18.6 in observation. The 3-year disease-free survival was 40.5% to 32.7% in the observation. There were about total 97 deaths. Either of tried treatment failure, be it local, loco-regional or distance, were 226 at the time of analysis. The 3 years local recurrence alone was 9.5% by port to 18.3% by observation as expected. And the distant metastasis between given a local radiation not are similar between either arm, that is also expected. So this is the modified intention to treat analysis Kaplan-Meier curves, and if you see, they have given a modified intention to treat analysis, a per protocol analysis, and at time of analysis depending on what protocol were followed. So in modified intention to treat, only the local recurrence free survival was statistically significant. However, per protocol analysis wise, the DFS also was significant in the port C data. So there were no grade 4 or 5 adverse events. Even the radiation pneumonitis grade 2 or less, and as well as the esophagitis were seen very few number of patients, and more or less were grade 1. There's only one grade 3 adverse events of one radiation pneumonitis. So what authors have concluded that following the modified intention to treat analysis, there is no improvement in DFS with the addition of port after a complete resection and the complete adjuvant chemo. However, there's improvement of local recurrence-free survival. The adjuvant chemo after optimal surgery remains the standard of care. Port is beneficial in fewer selected groups, few N2s, and further subclassification of studies are required. And this is the strongest point of this study is that this is the first ever randomized controlled trial of port to complete and conclude the primary endpoint and publish their data. So my take on a SWOT on this study is, this is the biggest strength is it was a phase 3 randomized controlled trial in line with the LONG-ART trial. It could adhere to the primary endpoint and has an adequate surgery followed by an adjuvant chemo complete cohort as standard of care. Port definitely has improved the local recurrence-free survivals and it is safe with the improvised radiation techniques. The weakness, the biggest would be, however, poor adherence to the modified intention to treat analysis, a single center study. There were no subclassification between the histological subtype and has a long enrollment phase. So a lot of things have changed beyond 2010-2015 in lung management. And a nodal yield, this is authors have only concluded, have not been stratified, which becomes significant in one of their publication itself. But this really leads to a lot of window of opportunity of port categorization based on histology and molecular markers, looking at only IMRT or further advanced technique related data instead of a club of 3D and IM and then realizing more of adverse events. We'll wait for other trials, long-term follow-up data. There's one German trial going on which is taking a 7-day RT trial, and people have also tried doing SABRE and SBRT in post-op setting. There were true randomized trials going on in New York. The threats are, one should not take into a practice changing, they're relying on a modified intention to treat analysis, and the center should be equipped to manage good salvage options in these local recurrences because they're bound to increase. Thank you.